So let me tell you what you just saw. IBM guy, full suit. Director of innovation, suit, no tie. Startup guy, jeans and rented jacket. So let me set the tone. Now what you probably are expecting is, being the startup guy coming from Silicon Valley, that I'm going to talk about technology and try to throw a bunch of existing systems under the bus. In fact, my goal is, this is a design conference. We're supposed to change the way we're thinking. What I want to share with you is those last 15 years of working in remote patient monitoring, which is a horrible name, telemedicine, but really thinking about the effect of place. So how does the place that we deliver care and we consume care affect our thinking really deeply? And if I'm successful, when you move into the forum, when you have conversations among yourself, hopefully when you tweet questions at me or to John, or you come up later, you're thinking about how you can change your perspective on place. In fact, the best thing would be is that I'm going to curse you with my face. And every time you think about place, you think about this conversation and how you might be able to change the way you think about place. So I'm going to start with the argument that place is so deeply ingrained in what we do, it's as prevalent in healthcare as the color blue. Look at all of these logos, these locations. Every one of them is a place. It's a state. It's a county. In the very way that we name our healthcare delivery system, we talk about place. Places people go, sometimes where they live, but it's all about going to a place, right? And so not every healthcare system has two famous brothers they get to name their healthcare system after. So maybe we're not creative, but I would argue that actually that's because we have 100 years of thinking about healthcare as place. It's expensive, there's machinery, there's lots of smart people there. It's a place you need to go, right? But even Mayo's not off the hook. As you drive down from Minneapolis, what's the sign you see on the side of the road? You see Mayo Clinic Health System, Canyon Falls, 26 miles this way. And I'm not sure which way this way is, but that's what the sign actually said. And I thought, that's great, I can work that into the slides, right? But this is what we know, right? Healthcare is a destination, right? It's a place. In fact, it's such a place that it affects how we spend our money, and it affects how we deliver care. It even affects things like licensure, right? State licensure, where you actually can provide medicine, where you can deliver care, right? I don't think any of you are worse doctors when you go to Nevada. Maybe you've been out in Vegas, and maybe you are, but I don't think you're any worse. You're any different. But it's pervasive. It's so deep. But what we've learned, and the data that I want to share with you, and the thought process I want to share with you, is we have to rethink place. This is your average, everyday, seen it a million times medical center, right? Obviously, high quality, because it's got a flag out front, and the main entrance is notified, right? We've seen a million of these, right? We spend $40 billion every year building new places. Now, look, startups are great at throwing around a lot of money. I've been doing that for a long time. The thinking about it part, not the throwing around part. And I don't know what to do with $40 billion. That's a number that blows my mind, right? I don't even know how to approach that. I know it doesn't scale particularly well, and I know it's a lot of money, right? But what do I do with that? How do we boil that number down to something we can actually manage? Recently, Johns Hopkins built a couple buildings. They published this all on their website. I'm glad to share the sources. And they said, we've got this great new building, and it's effective, and it does all these great things. And in the first year, it will add $10,000 to each visit. That's a number I can understand. And they're not running from this. This is published. $10,000 per visit added to the cost. And part of that is because we've decided, well, this is what patients want. Bigger TVs, private rooms, nicer beds, prettier carpet, better food, right? And you look at survey after survey, and I've sat down with these organizations and looked at the surveys, right? Looked at the data. And the part that they miss is the first part of the sentence. Well, if I have to go somewhere, a bigger TV would be nice. A better bed would be nice. But you know what's nicer than the TV at the hospital? The TV at my house, the couch at my house, or my grandkids' house, or wherever I want to be healthier. But we miss the first part of the sentence, and we're really good. Everyone in this room has said patient-centric probably 10 times in the last 2 days, right? But we're not listening. We're not listening to where they want to be and how they want to consume care. Now, you're all thinking right now, wait a minute, no one's gonna do surgery at home, nobody should be, there's reasons to go places. Of course there are. I'm not saying that we shouldn't be building buildings. I'm not saying that we shouldn't have destinations. But if we're really going to be patient-centric, we wouldn't be building things with doors that lock, with buildings that close, that have open hours, right? That a patient-centric model would start with where as one of the key questions. And we don't. As much as we say we want to, we don't. Now, so how can we change? We always want to look for analogies. Healthcare is great. Every healthcare conference you go to, someone's going to make an analogy. And they're usually going to make an analogy to this, right? Banking, financial sector, right? We love to make our financial sector comparisons, right? It's regulated, it's got real estate, right? And then we can put up great stats like this. 10,000 branches closed in the last few years. That's a lot of branches that are closing, right? So far, it seems like a good argument, right? I like this analogy. It works, right? But 3 states, Wyoming, Idaho, and Alaska, built 0 branches. Literally put 0 branches in, bank branches. So as we keep our love affair with banking and the financial sector, that's interesting. We could start to say, okay, interesting, maybe we build no places. I'm not saying that's the right thing, but it's interesting to see what's going on there. Not only is it plummeting, there are places that have built no branches, and that's rural. That's where people need to travel to get services. Now, the other part of this analogy, and the one that drives me bonkers, is when people say, oh, so what we need to do is figure out what the ATM analogy is for healthcare, carry the one, healthcare is just like financial services, figured it out, right? Please, if you could do anything, please stop this. Because that's what's wrong with healthcare. We're making analogies to things that were cutting edge 30 years ago and saying, oh, we should just catch up with ATMs. No, you know where finance sector is now? Finance sector is mobile payments, is things on your phone, micro payments, texting, watching what's going on in Kenya with micro payments. Some of this stuff will fail, some of this stuff is crazy, right? But ATMs is not cutting edge, right? So as much as we like our financial sector stuff, and I'll use the data, of course, on them closing banks, this isn't the answer. The answer is to try to leapfrog, to try to catch up to where people want to be and how they want to consume care. Because now, if you talk to anybody under, let's say, 35, 30, the idea of going to an ATM is a pain in the you-know-what. An ATM is not an innovation anymore. So who's the leader in this space? I was lucky enough early in my career, I'm not a doctor, that's probably pretty obvious, as I came out of the technology sector to work with the VA, work with them in a lot of their pilots and a lot of the visions, and the VA throws a curveball to healthcare. They have their 22 visions not named by state, so it doesn't look like they're thinking about place, but they do too, right? And in 2004, they started a national program. In fact, they just published their paper on 20 years of telemedicine in the VA. The last 10 of that I got to participate in significantly and was the biggest vendor and worked with them on designing the programs and also made a lot of mistakes. They're going to serve 1 million patients next fiscal year, 1 million patients with remote care, right? Now, this is another one of those things too, with words. This is a good chance for me to interject this. Please don't say e-visits. Please don't say patient-centered connected home. Because just like Tampa General or Florida General, those words are limiting your thinking. A patient-centric medical home is great. What happens when they're not in their home, right? E-visit means take the visit and make it e-ified, right? First of all, no one says e anymore, so just stop that, right? But if you're going to e-ify something, don't e-ify the visit, because we're not doing a good job at visits right now. Right? We're struggling with typing into our EMR systems. We've only got 8 minutes per visit. So don't limit your thinking from a design standpoint to these old constructs. When you go into the forum today, try to think bigger, to challenge the words you're using because they're limiting our thinking. So, million patients. This is what we should think about that. They've done a great job. Dr. Darkins and his team have been great, but it's only a million, right? It's only a million. We've got to be thinking about how we're touching everybody, because they're looking at chronic care and they're looking at the high-end folks, right? But everybody has to think about their care differently and where they receive it. Now, did it work? Well, this is the worst outcomes. This is across all the disease states. Heart failure, of course, doubles and triples this. Different disease states are different, but this is everything. Across mental health, right? You know what the best part of these is? Take the numbers off. I could have put XX where the numbers are. These are metrics that are patient-centric and not thinking about place. You know why? Because patients don't want to be in that bed, and patients don't want to be admitted. So we've got some good data that it works, right? We've got some good data we can do it at scale, right? They spent $1,600 a year per patient. This is 2008 data, right? So 10,000 per visit, 1,600 per year at high-end chronic diseases all the way down. This was it. It's fully loaded, costs, everything. I can tell you the technology part, we did not get $1,600, right? That's the whole thing, right? What that should tell you is we're heading towards a cost curve where patients can get involved, where patients can say, how do I actually pay for that? Not today. No patient's going to pay $1,600. Probably, right? Would be nice, but probably not, right? And certainly there's people that can't afford that at all. And Medicare has their programs, we can talk through that later. But this is a price curve, which means we're getting towards a consumer market, and that's fascinating about how that's going to change place. So then the question always comes up. Whenever I talk to doctors or people about this, they say, okay, well, you're giving me a choice, right? So is this a cost issue? What about my relationships? And let me stop right here and say, I'm not Silicon Valley guy. I guess I am that, but I'm up here as a patient. I have a heart defect. I use this stuff. This is not something that is, I want to just have technology because I'm from Silicon Valley. I don't want my doctor telling me things are worse over technology. I want to still have relationships. But you know what? My doctor's too busy to have that relationship. I go, I run on a treadmill once a year, and the way he phrases it, he doesn't say this is what I hear. You're not going to die today, right? But that's the relationship. I don't have a relationship. I have a heart problem and no relationship. So forget wellness, forget all this low-end stuff. I have a heart problem and no relationship. That should scare the crap out of everybody. So it's not just about this. We've got to figure out how to have both of these things. This is the VA data, right? 86% of the people increased their satisfaction. They felt more connected. Now, this was not FaceTime. This was not video. This was a little plastic box with 4 buttons and basically the equivalent of 3 or 4 lines of text and a whole bunch of questions, about 15 questions every day. They were personalized. They used the person's name. They knew their risk parameters, and they talked to them. This was not, oh, Silicon Valley guys trying to get everybody to buy an iPhone. No. This was a phone line. This was an RJ11 jack that every single person has in their home. Maybe not anymore in some places, but this was in the Bronx. This was with Montefiore. This was the VA. This is the hard cases. This was not just give everybody an iPhone, right? This is people feeling more connected. And that bottom number, I don't know how to think about that. I don't know if that means that people just feel horribly unconnected or this was such a big increase. But the bottom line is they didn't look at that box and go, oh my God, my doctor's forgetting me. They went, oh, thank God, I can actually get somebody to call me, talk to me, interact with me, but not video. I don't need broadband. I don't need a cell phone. This is what we think of when we think of mobile. Now, I just told you about my condition. Yeah, that's not me. I'm not that old, young, I guess. I do carry coffee around. I do carry my phone around. So do all of you. Stop thinking about mobile technology, whatever that might mean to you, whether it's these little devices or phones. Stop thinking of those things as young people devices. Just like you should stop thinking about the VA as those are old people that fought in World War II. No, those are Iraqi veterans. Those are people who are dealing with PTSD and other things. Break the stereotypes. When you break into these groups today, get away from those stereotypes and rethink how this works, right? Redefine this consumer, but the key word is consumer. As that price point is dropping, people are going to pay for this themselves. And that's the company that we've started with Mayo Clinic, right? With the Mayo Clinic, we have started this personal health assistant you've heard about. We have started a way for people to start to get this care coordination services, excuse me, themselves, wherever they might be, however they want to interact with it. Because what they said to me when I was running the one with the VA, said, how do I get that? And the other biggest customer has the National Health Service in the UK. So basically I had to say to them, well, you can fight in a war, or you can move to the UK. That's the only way you can get it. Now I tell them, go download it. Get started today, right? This is the argument I would make. Patients are telling us they want these things, but we're not listening. We're still building buildings. We're still thinking about place. We're not challenging the notion that we can reach people where they are. So we get 30,000 new users a week. It's not that many yet. We're growing. It's brand new, launched earlier this year. But 30,000 users a week, within 3 seconds of downloading the app, tell us what they want from healthcare. This isn't randomly sampling 1,000 people in the mall. This is 30,000 people each week telling us what they want. And we can adapt rapidly because consumers will tell us. We've just got to listen. I want to share 3 things with you really quickly that we've learned over the last 3 or 4 weeks of these numbers of these people downloading. 1, people see healthcare as equal parts administrative and clinical. You look at them potentially as a diabetic or a heart failure patient, maybe even a pre-diabetic if we get down there, which would be great. They're also thinking about insurance, appointments, prescriptions. They need help and care coordination across all those things. Those are independent of space. This group of people, the average age is a little over 30. For every 1 phone call we do, we get 40 messages. 40 messages about their health care. And when we say, well, we'd like to get on the phone, we'd like to talk to you, they say things like, I'm on the bus right now. I don't want to talk about this on the phone, right? Or I'm at work, I wanted to send off a quick message. I need help with these things, I want to ask a question. But we're able to serve them wherever they are and whatever time they need help. Our doors are not closed. We don't have doors. This is the one that also gets me. 75% of the transactions outside the workday, which means they're doing stuff when they're on the bus, when they're at home, at places when a traditional office or location might be closed. So when we look at this data, and we're literally like in the green room watching this data coming in about what people need, we can listen, we can deconstruct our bias on on place, and we can start to think about serving patients in a truly patient-centric way. Now, one of the reasons in these last 10 seconds that this is really important and why we work with the Mayo Clinic is because this is fundamentally going to be about sharing knowledge and how we distribute that knowledge to people wherever they might be. And so as we start to think about these relationships and we start to think about how space works and how place matters, think about that deconstructing your biases on who your users are, where they want to actually work with you, and what does place mean to them, not what does place mean to you. Thank you.
I guess I shouldn't really be surprised that a guy, last name is Clapp, gets into healthcare, right?
Well, so here's the thing. So not only is my name a verb and a disease.
Yeah, right.
So when you're like 0 to 10, it's a verb, and you're 10 to 20, it's
right.
a disease. And then I started a company called Better. I mean, like, I'm just all about the wordplay, clearly. So
that's great.
Yeah.
How much did it cost you to rent that jacket?
So, well, if I return it quickly, maybe nothing. So that's,
okay.
Use the tags on the inside.
A zip jacket.
Yeah, exactly.
There we go. And a lot of questions here for you. Oh, by the way, you mentioned the relationship. You have a heart disorder, and you'd love to have a relationship, but you don't have one, right?
Right, correct.
If I could give you one,
yes,
packaged in a little box, how much would you pay for that?
Oh, I'm so tempted to give you the line price of my company, but I think that I would pay exactly what.
What do you think the market price for that relationship
$20.
is? $20.
And here's why. Because I want to be able to use my health savings account or my FSA dollars. I'm not going to spend money that competes with Starbucks. I'm going to spend money I don't know how to spend. There's a lot of studies that show HSAs, 15 million people with HSAs last year don't know how to spend it, right? If we can link into that money and say, look, that's for healthcare. Spend $20 a month on your healthcare, right?
$20 a month, okay.
$20 a month.
20 bucks a month.
99 cents a day.
Subscription.
Subscription.
and how many visits, how much time would you spend cultivating that relationship versus the value of just knowing that you have it?
So I think the analogy is like AAA, right? For, I know Uber came up earlier, but for those that still own cars, right? I have a AAA card. When I break down, I know that they are there. I don't need AAA to call me every day. In fact, it would be pretty annoying if they did, right? But I want to know they're there. I want to have a trusted partner. And honestly, I want to know that there's somebody who works for me. We didn't really get into this, but right now, the patient, nobody works for the patient. Insurance companies, all of the convoluted incentives that we have. I want someone who's on my side, not my employer's side, not my insurance company's side, someone on my side.
All right, here's some questions from the folks out there.
Great.
Did the VA really reduce its visits, admissions, and bed days with telehealth, or was it management, financial incentives, and bonuses?
So the best thing to do is that person, we could talk, I'll give the person the paper, I'll take them through the data. So I will tell you this, no one on that team got bonuses, much to their chagrin. There are certainly incentives. Look, when you carry risk like the VA does, there are different incentives there. You heard me mention the other big customers, the National Health Services. Same kind of thing, where these incentives are actually kind of perverse in our market, right? So there's certainly more incentives in the VA market, but the reality is that there's data and paper after paper. This is not new. That data is 10 years old.
Right.
There's 100 papers like that. We got to get past that stuff.
One person says, you're doing great, Geoff. Based on the variety of experiences you've had, what's the top 2 tangible things you want to accomplish in the next 2 years?
First, thanks, Mom, if you're out there.
Right,
I didn't know she came to Rochester. That's nice. Actually, it would have been Geoffrey if it was my mom. The next 2 things, look, we got to get this more accessible to people. I think, honestly, with Obamacare, high deductible plans, HSAs and FSAs, which I mentioned, healthcare is complex and confusing right now. So as much as there's opportunity for consumer, we got to help people understand they can expect more from the system and give them a way to actually get it. Right now, it's the wild, wild west out there for consumers, and their perception, whether it's healthcare.gov or other things, isn't, oh, you're ready for me as a consumer. It's a pretty scary place for consumers. It's consumer education. It's probably the #1 thing.
Last Yorn.com question here. Would you prefer we start designing, since you love to play with words, would you prefer we start designing people-centric health delivery instead of patient-centric?
Oh, my God. Whoever that person is, I love you.
Oh,
that's fantastic.
All right.
Yes, absolutely. I think the problem is as soon as we start using patient-centric as a term, something's already happened that made you a patient, right? And even if that's pre-diabetes or pre-hypertension, why can't we start designing a healthcare system that puts the person and the individual first? Because as soon as you're defined
let's extend that. And that really takes us right back to the very beginning of today's sessions. How can we encourage people who are healthy to think about their condition as urgently as people who have been told they have cancer? That's really the question.
Well, so let's use, I'm gonna use myself as an example because it's just a little easier. I have a 9-year-old daughter, right? I don't do a good job of going to the doctor, and I have a heart condition I just told you about.
But you're all over her healthcare, right?
I'm all over her healthcare, right? I am all over her healthcare. I mean, honestly, I use the system more for her than I do for me, right? So part of it is, we gotta link into the human emotion about who we're caring for. Honestly, I'm counting on her in 20 years to now flip the model and care for me. I think if we're trying so hard to change behavior, whenever we start talking about, let's change behavior, let's link into behaviors that already exist. Where is the human empathy? Where is the human emotion? Get into those things first, right? Get those people to understand how they could care for each other, and maybe some of that will pull in. But if we're gonna spend all the time trying to change my behavior, right, it's very likely that model's not gonna.
But I'm thinking app here. Okay, so you care about your daughters.
Yes.
Your encounter with the healthcare system is through your daughter's healthcare.
Yes.
What if there was an app, a little graphic that would come up on your device from your company or anybody else's or a smartphone that would basically say, okay, based on your experience with the healthcare system, your daughter's longevity is this line. But based on your personal encounter with the healthcare system, daddy's gonna go away at about this age, which links suddenly your health directly in with your daughter's health.
So it's all about the delivery of that information, but I'll tell you, the most compelling interactions that we've ever seen with physicians on behavior change, if we're gonna go there, is using the Framingham study data and showing exactly that, which is I had a doctor say to me, I was a little bit overweight, I got really scared about my heart condition, stopped exercising, didn't eat well, and the doctor said, so, Mackenzie's my daughter's name, so the end of her sophomore year is probably when you're gonna pass.
Whoa.
Don't you wanna see her graduate? And of course, I went and built that app, and I can tell you how I'm doing against where she is. Now that's a little extreme, of course.
But it's how culture
Exactly.
interacts with behavior.
Exactly.
That's the deal. And that's how you get culture to not eat strategy.
Exactly, and I'll tell you, when I go and get a flu shot for Mackenzie, when I go and somebody reminds me, it happens to be through our service, and says, hey, here's the closest free flu shot, we've arranged this for you, they're ready, go. Get it for Mackenzie. By the way, while you're there, let's get you one too, right? I'm not going for myself, I'm going for her. I just happen to be getting those things while I'm there. We can link into that human emotion that already exists, rather than try to change everyone's behavior at the start.
Geoff, thanks so much.
It's a real pleasure. Thank you so much.
Thanks.
Thank you.